right away. Uh, you're seeing a lot of clusters nowadays. So the whole talk is about whether clusters and tasks is increasing or not. Um, I'll go first with introducing the subject. So can I have my presentation, please? Right. So the question is whether clusters or tasks, is it increasing or not? Let's see some statistics. India has done well as far as the number of cataract surgeries is concerned. We may have done about a crore surgeries in the year ended on 31st of March 24-25. So as far as numbers are concerned, we are very happy. All right. But when we look at the causes of blindness, the epidemiological survey results, the 86 to 89 national survey, it showed that overall blindness had 5% contribution of surgical complications. Now, when the recent survey was concluded and published in 2019, the RAB survey, the overall blindness has gone down, but the contribution of surgical complications has gone up. It is about 7.2% of the total blindness. So that answers partially our question. If we look at our performance of the Adverse Events Committee over last 1.5 years, we have seen almost one episode, either a cluster or task, every month. We have seen 6 clusters and 12 task episodes were reported. 4 clusters were reported from Gujarat last year in 2024, which were not reported to the Adverse Events Committee. In fact, the number of unreported incidents are much more. We are afraid that only about 10% of these episodes get reported. If you look at the clusters, sharing of consumables was found to be the cause in 2 cases, and poor adherence to protocol was almost universally seen in all the clusters. Investigating these episodes poses major challenges because hospitals do not want to share information with us. They don't want to send samples for testing, and sterility testing requires good number of samples. Only then tests can be done. And pyrogen testing in labs is also taking a long time. So by the time the reports come, probably the whole batch of that particular material may have been used up. So these are some of the issues. If you look at the TAS episodes which were reported, 3 company IOLs were implicated, 2 company irrigating fluids were implicated, and viscoelastic, silicone oil, lubricating eye drops, bandage contact lenses, injection pilocarpine, and anti-VEGF drugs were also supposedly causative of TAS at some places. Friends, what happens after cluster getting reported is loss of name and fame for that doctor, and the hospital is naturally there. But in addition to all that, the OTs are ordered shut down by the government for prolonged periods of time. At places, ophthalmologists and or trustees were jailed, and licenses of some of the colleagues was suspended temporarily. The performance overall in the whole state drops for that particular period of time, and there are overwhelming amounts are sanctioned as reimbursement to the patient. Many times these decisions are ad hoc and baseless. We do not agree with all that, but we cannot help the situation, and even judiciary has taken similar decisions in some instances. So we believe that infections and TAS is a major challenge for the ophthalmologists, but we don't know what is the incidence because very little gets reported. We really don't know how to prevent them. There are a lot of guidelines available, but either guidelines do not reach us, or we do not agree with those guidelines, or we don't follow for whatever reason. And then quality versus quantity and quality versus cost are major issues in our country, particularly for the charitable activity where the surgeries are being performed free of cost. We could investigate a few cases of clusters, and I have personally done a lot of audits of several hospitals in the country. What we had seen was, in terms of the protocol, either people are not aware of the protocol, or actually the protocols were not even existent in that hospital. They did not follow any particular protocol. Whoever was working in the theater would do whatever he or she had understood. And if the protocols were there, if the guidelines had reached them, there was lack of agreement with the protocol, mainly for financial reasons in charitable activities. If you look at the infrastructure, lack of enough number of instrument sets or equipments against the numbers that the hospital was performing was found to be a major issue, and improper layout of the theater was also seen in some of the cases. Lack of properly trained or qualified human resource was also found. Number of human resource available against the number of surgeries that the hospital was trying to perform was also an issue, and very poor documentation was also seen in some of the instances. We want to reduce the rate of endophthalmitis in the country and reach the Western standards, which is 1 in 10,000, 0.01%. And even AIOS is targeting zero tolerance to infection by 2030. How are we going to reach there? We need to follow the guidelines. We need to maintain discipline inside the OT, and all of us need to become quality conscious. In India, chalta hai is our attitude, and that needs to go out the window, at least for the operation theatre activities. There are several guidelines available to help us. The AIOS guideline, which was published in 2018, NPCB has also published a guideline. Government guidelines are available. Dr. Nirmal sir will talk about it. There are manuals available to understand the science of infection control. There is a textbook available. There are infection control journals available. There is something like Hospital Infection Society of India, just like All India Ophthalmological Society. We can become members and get updated. I just want to remind you one very important thing. The poorest of the poor patient is at the highest risk because he is malnourished and has very poor hygiene. So if at all we want to follow stricter version of the protocol, it should be followed for this poor patient. In general, we see the reverse. We use the best protocol for our paying class of patients, and we compromise when we are working with poor patients. So I just want to remind everybody that that's not to be done. Reverse needs to be done. There is an adverse event committee formed by the AIOS. There are 28 members, all experts from across the country. We request all the members to report 2 or more cases of either TAS or endophthalmitis occurring at their place. The information shared with us will remain confidential. The link to the portal is given here, and we request everybody to report, so that once reported, the committee will come into action. And as I told you, we could investigate some of the cases. If we can get into more details, maybe our protocols will become better over a period of time. So I believe that helps you understand the fact that the TAS and infections are on the rise. Thank you so much.
Thank you, sir, for the setting the stage for this course. I'd like to invite Dr. Chandrasekhar to talk about the various scenarios of clusters.
Excuse me. Thank you, madam, for the invite. Thank you, Uday sir and AIOS Adverse Events Committee. So what I'm going to talk in the next 10 minutes is about various scenarios of clusters, in what all way they can present. You can go to slideshow. Yeah, thank you so much once again. It's a smaller crowd, but for the magnitude of problem that is occurring in the country now. This is a very warm vanakkam from all of you from Tamil Nadu, Coimbatore. Sir, it's not moving. Okay. So the idea is to, just to make you aware, it can present in many, many forms. Nothing against anybody. From doctor as a role model, as a god, we have gone into patient-centered now, and patient knows everything more than us sometimes. So when it becomes an infection or cluster, it becomes difficult. Most commonly performed surgery in the world, and more than 8.3 million surgeries done in India alone. So sir has given you that when you see an end of post-op, be it one case, it's a real nightmare. It's going to be big nightmare. But when you see many of them like this, it's a nightmare of nightmares. So from the era of where we were couching, now we have gone to modern theaters. Our protocols have changed. No more. We have gone into HEPA filters with AHU. We have gone into horizontal autoclaves which are well validated. We have moved to era of class 6 validation, but Bovidix and so on and so forth, to make sure our process is absolutely fantastic. And this gold standard biological indicator has transformed the validations, and with so many protocols, still are we safe? We have intracameral drugs, everything being given, and the number of end-off have reduced multifold, sometimes 4 to 5 times in the country. As by Arvind's study, you know how much it has reduced. So the antibiotic policy also is now comprehensive. It is towards the prevention of end-op, pre, per, and post-op. It can be end-off or it can be a cluster of TAS. Surgical site infections are within 30 days of the surgery, but when we put an implant, then it becomes within 90 days. This is the definition of a surgical site infection. 5 cases or more are defined as clusters, but I would advise, even if you get 2 on a single day or on 2 consecutive days, take it as cluster and work towards it. So hospital acquired infection, sterilization breakdown is one of the most important things. Consumables, where sometimes we do not have any, even if you do batch testing, there could be one where many things between the producer and to the place where we are consuming, the transport is there. So many things can happen, and single case can become multiple because of our protocol. This is one of the alerts that has come in Indian journal. 1 in 100, it's an alert. 2 in 600, 1 in 75, red alert is 2 in 200. So these things are important for us to wake up and make sure we don't go on to get clusters. Now coming to my topic, botched eye surgeries. This is the commonest term used by the media anywhere and everywhere. What do we mean by botch? We have messed it up totally. We have done something bad. That is what the people also think when they see the media. It is very interesting for the people who make a news of it, but when the person reads, it is the name of the surgeon, it is the name of the hospital. So these are various things we see in the papers and the various channels. This is one scenario, one of the biggest in our country, where 65 cases all operated went in for cluster endophthalmitis. It was shown that it was Pseudomonas gram-negative, and unopened bottles of ringer lactate had this organism. So then it went to court. Then there was this thing. After the court verdict, which was in favor of the hospital, there was a Human Rights Commission which went and said there is something wrong. They've consumed this, that, and all. It went into CBI. So it went on for a long period, almost a decade, went on and on. Imagine the trauma, not only for the 2 surgeons, for the management, but also for 50 employees who were called to CBI in Chennai to be interrogated. It is not a joke at all. Ultimately, what happened was the hospital won, but they had to spend crores of rupees, and compensation were given to the patients. In scenario 2, on first post-op day, 15 of 23 cases developed a TAS. And morning the surgeon and everybody saw, and then immediately, the beautiful limbus to limbus edema, there was some kind of AC reaction. Steroids were started, cycloplegics were given. By evening only, many of them became all right, and within 2 days, all of them became all right, and it was a happy ending for both the patient and the doctor. So very happy. So what happened 6 months later, again the same 2 surgeons operated, 12 out of 25 cases, similar finding, again limbus to limbus edema, ASC reaction. So they believed it is the TAS, and the same kind of management was given. So one was a visiting surgeon, the other one is a in-house surgeon. Evening, that surgeon calls and says, out of 12, 7 or 8 are little better, others are same, something like that. But the next day morning, all of them turned out to be a cluster end off, and it was due to gram-negative pseudomonas. What was happening is the IV steroids was suppressing the inflammation on day 1, gave a false hope that it is not an infective case. So again it went to court and all, but the protocols were good enough. Then actually what happened, they took to street, these 12 people, they brought the media, and there were about 7 or 8 departments which came in. End of the day, it was proven the unopened bottles of ringer lactate from one company had pseudomonas. But when it went to court, all other protocols were proven. But the hospital went against the company to say that it is your bottle of ringer lactate which was contaminated, causing these infections. You pay the compensation. That fellow gave one line answer, this is not meant for intraocular use. He made himself safe. Ultimately, the hospital managed, and when they realized they were trying to take money, the lawyers and other things, then they came and took whatever compensation was given, and the case was withdrawn. So this is ringer lactate again. Now this is a case of 9 out of 12 cases at cluster end of about a couple of years back. The main reason was they were sharing intraocular consumables. Actually if you look at the cost, it will cost you 100, 150 only. But the same consumable was used for 2 sets of patients, and not one, they were using 3 intraocular consumables. So then ultimately one of them had a same cluster, and it went on and on, but it was because of sharing of consumables. Actually four intraocular consumables were shared between patients. One of them turned to be infected, and that was the cause for the cluster. Again there it was a gram negative bacteria. Now this is another case in the south where I got reported that 40 cases were infected in 2 years, which is a big percentage for that particular hospital. So a thorough workup was done one whole day, sitting with the team and looking at it. Ultimately we found out it was only class 1 indicator they use. Class 1 indicator is nothing but the strips. It only says you switched on the autoclave and switched it off. It doesn't say it was done effectively. Only half the time it runs, the color will change. So they were relying on this class 1 indicator, and no class 5 or class 6 or ovoidix was used. Ultimately, the validation showed that the autoclave was at fault. And then once they set it all right, everything became all right after that. See, this is another scenario which is avoidable. We have gone, I told you, from 20 years back, these validations are no longer a luxury, it is mandatory. Dr. Haripriya madam is there, she is in charge for OT protocols at Aravind Eye Care System, and she has created a beautiful protocol, and it is not just about protocol, you have to follow it up also. This is cluster endophthalmitis in a secondary hospital where 3 or 4 cases consecutively occurred. So then after every workup showed there was no organism, and this organism was Streptococcus dysgalactiae. Ultimately I was there with the microbiologist. We decided to take throat swabs from that was a fixed team, and that nurse who was actually assisting all the cases had a subclinical infection of the throat swab. So it was sent to even Italy at that point of time, genetically proven it was the same organism. So all these are developing into the protocol. This is another case how it presents. Now the reactions due to an intracameral drug we have seen because of multiple batches. Recently I am talking about multiple centers. One center had end-off and others had TAS reactions. So again, the most important, we talk about the sterility. Apart from that, the endotoxin levels are also equally important, especially when we talk about implants. Then this is the one which occurred a few years back. Multiple TAS related reactions due to an intraocular lens, all similar ones, and the endotoxin levels were very abnormally high, and that was the cause for the TAS reactions across the country. Now cluster of, there is one that was reported probably 6 months back. IOL injector was the cause. The fellow had changed the injector. Immediately they had about 6 or 7 cases when they used it, and then again he replaced it. Again the endotoxin levels, which are very important. So other strong accusations, this is when they go to court, no evidence of in-between cleaning. Can you imagine, it is not done by the patient, he is guided by our own people. Otherwise, where they're going to get an idea of in-between cleaning of cases? Lack of communication regarding status, not clearly explained. That's why I always say, when you see on day one, it is easier and best to talk and document with signature, which is lot easier than on day 4 when they all become more agitated. Same instance, recording of communications they do today. Recording is not impossible. Everywhere, by every form they record, and that becomes an evidence for them. As well as social media, it brings us down, which may not be really justified. One case, they operated right eye, 6/6 vision, superbly doing by a tertiary care. He was very far off, about 300 kilometers. Went back to his town. I'm done. 1 minute. Went back to his town and showed to his doctor and said, beautifully done, there is no problem, but only a discharge summary says left eye done. That fellow ungratefully went to the court, and it is almost on the verge of verdict in a few months, and they proved that it was wrong because there was no informed consent for the right eye. So the court said, you don't know, you have done on the wrong eye, and the claim is 60 lakhs for a perfectly done surgery. So these are the things that can happen. That hospital which had 65 cases, it was a 10-decade struggle, and they spent 10 crores. Imagine, whatever, and a good name gone, and they are on the upway path again. They are trying to do very well. So again, out of the 12 I told you, earlier 9, 2 have gone to court asking for 50 lakhs each. It is still happening. This was one of the from the IOL company saying that they have withdrawn, recalled some kind of. So these are just the tips of icebergs. I'm sure you will all understand that we need to work, and not just work, review. We have to make sure what we are doing is good. 0% incidence is a dream, not at a reality. Thank you so much for the patient hearing.
So we'll have discussions at the end, and I would request all the audience to write down their questions. May I request Dr. M.S. Ravindra sir to please do his presentation. I think if for all the audience here, if you have to understand how a protocol is to be implemented, please visit his eye hospital in Bangalore, and you'll be shocked that how much what practices we are practicing would be so much under the level of what is to be expected. I would request all of you to go and visit his hospital once and see with your eyes, because what we tell you, it might not be very impressive unless you visit us. And he is a master of how to implement all the strict operation theatre protocols. And let us hear it from him himself. Sir, over to you.
Thanks to all my friends on the dais and my friends down here in front of me. I really cannot cover in 10 minutes time whatever I wish to cover, but let us continue this talk after this on various forums.
I mean, is it audible, please? Is he audible there? Audible, can you adjust the mic volume?
Yeah, what I was trying to tell is that in 10 minutes time it's almost impossible to cover a very large topic like this, and we should form a forum. I'm going to raise it for you. Raise it, okay, thank you. This is necessary, raising. So let us form a forum here and continue this discussion. I think that's what I would like to suggest. I'll quickly go through the processes. Processes to avoid TARS and infections can be at the patient level. Patient needs to be prepared well. Let me not go into details. Our operation theatre structure and function both have to be under good care, good control. And our surgical team, as human beings who work in the operation theatre, have to do excellent job, and they have to understand, and that has to come from the heart and not from monitored by somebody else. It's very difficult to achieve, especially in Indian scenario, but that's what we should aim at. So when I say patient preparedness, it starts a couple of days beforehand. What we do is, as soon as we diagnose a cataract in the outpatient department, but especially the lid scrubbing instructions are given to the patient then and there. Use either shampoo or anything else and keep cleaning the lid margins. He may undergo surgery 2 weeks later, but there is nothing harm. When we wash our face, usually the lid margins are not covered. So you can do it yourself, but then we don't scrub the lid margins. That specific instruction itself will reduce the oil slick that you find during the surgery, which is bad. Antibiotic profile, the other things I would like not to do. cover it up now. Betadine scrub is very important just before the surgery. As soon as the patient comes, he'll get antibiotic drops, dilatation drops, and once the surface anesthetized, we do put a betadine drop into the eye directly. It's commercially available, the 5% drops, and it's not irritable especially after you put it. Then that's and clinically examine the lid margins. You would have seen in the OPD a couple of days before, but examination just before, please with the torch or little magnification on a slit lamp is very good. And OT transfer has certain protocols. Every hospital has got different ones, and that has to be looked at. So OT preparedness, monitoring sterility, that we will talk about it. Surgical team has to, everything has to come. You have to specifically take people who are good at it, who are honest and humble, not the people who show off. This is a selection process itself, it has to be different. Your street clothes, the clothes that we wear right now, walk around everywhere, will shred 1 crore particles every minute. It's shredding that much of thing. So whatever time you get into the operation theater, kindly change to the clean clothes and then only go. Surgery is over. Tomorrow we are going to get fumigation done in the OT, so we get inside with the clothes on, which are used outside is not permitted. Every entry, alcohol, hand rub should be there. Hand hygiene complication, every entry, door, you put alcohol and make it a habit to alcohol. All of us know. Sterile gloving and gowning again is very important. I'll have to rush through. These are things which you can take a photograph. Let me not cover it. And betadine scrubbing is very important. One of the key steps in surgical infection control protocol. This is something which you'll have to learn yourself and practice it. Good practice is to avoid the wrong patient, wrong eye being treated under somebody's name. This is possible only if the patient carries a case sheet everywhere. Patient or attendant has to carry a patient. There are at least 5-6 stations patient goes through before he gets discharged. The case sheet has to be accompanying the patient all the time. The staff should minimally move inside the operation unless you have a good AHU, handling AHU unit is there. Then movement has to be absolutely reduced. Double gloving in case of high-risk surgeries. Timeout procedure. This is one of the important things that we practice. Before starting the surgery, announce the patient's name, all the conditions, medical conditions, and the medicines that he is taking, the right or left eye, and procedure confirmation, what surgery is being done. You may be doing a lid surgery, but then you may go and do an incision in the cornea, so that becomes a catastrophe. So any instrument that is contaminated, suspected to be contaminated, has to be thought as though it's contaminated and remove it and change it up. We have a practice where we don't use, we stock at least 3 months stock, and first purchase is first utilized, and only time tested party. Anybody trying to give samples to us, they try this out, they'll find dustbin. We don't use them. So store at least for about a month's time before use. That's a practice we use. It's in the hospital store for at least 1 month before it's utilized. So in case there is a contamination, it will start showing the debris in the packs. Inspect against light like this, as well as in reflected light, and then you will pick up the particles. Don't shake it up, gently move it so that you see the particles moving around in case it's contaminated. Vacuum seal has to be seen. If the vacuum seal is released, it's unsterile. And never use galley part on the trolley. Store used packs. This is used one. We don't discard it. We put it in a plastic cover and label it and put it somewhere, and after 2 weeks we'll discard. So in case there is a patient has a problem, we have something that is available with us for investigations. Check the label of the ampule. Many of them are very tiny ampules. They may be color coded, which we do not know. The print is so small, so wherever you kept the ampules, keep a magnifier so that you can magnify and identify the medicine. It's very important. And then always pour a drop of alcohol onto the top of the bunk there, and wait for 5 minutes time. The alcohol, you wipe it with a cotton swab. It doesn't become disinfected. You'll have to pour it like that, what you see there, and then wait for 5 minutes till it becomes dry, and then only you put a needle inside. This has to be for all Xalocaine, Avastin, Fibrin glue, whatever you use. That's the 80% alcohol is better than 100% alcohol. The ampules, we don't use it because the splinters could have gone inside. When you break it, the splinter has got a sterile surface and an unsterile surface. One splinter goes inside this. Out of 10 ampules in our study, 1 or 2 has got splinter inside. So what we do is we never use the ampules directly. It goes into the autoclave, and all the medicines, fortunately, that we use in ophthalmology are thermostable, and then on the table itself, we'll open and take it. In case splinter goes, then it's still safe. So these are practices. Always buy packs like that, which peel open type packs. Open it up. The person who gives, the hands are below. The person who picks up, the hand should be above. This is actually wrong, and tearing off also is wrong, and that's the right methods. And whenever you pipes, tubes and all come to the surgical table, at the entry side, you fix them with tapes. Otherwise, these tubes will go outside, become unsterile, and again you're going to drag them inside. The entire field becomes unsterile. Avoid using anything that is used already. This is a slide which I've been using for 15 years. Change all instruments, everything, every surgery, whether it's a gown or glove or instrument, whether it's a diathermy probe, whether it's a vitrectomy probe, phaco tubings, phaco tip, phaco sleeve. We have no business in reusing it, though the practice is something else in most of the hospitals. And buy equipment that are compatible for use. OT disinfection and cleaning procedures, there are a lot of videos available. Let me not spend a lot of time on that. Post-operative care is very important. Examination of the patient very next day is important. And hand hygiene, if you practice hand hygiene, wash your hands, sanitize them, and touch the eye, the patients are going to see and follow it at home. If you do it with an unsterile hand, patient will follow the same thing at home. So not only for maintaining the hygiene, but also to ensure that the patient follows these protocols at home, these are necessary. So that's the way all the instruments that are there should be on wheels, so that they're including the dustbin or microscope, everything, and including the OT table that you buy has to have casters so that it can be easily moved around, so that underneath that you're going to clean it up. These are our operation theaters. We have 3 of them. They're all AHU controlled, and enough space should be there in the operation theater. At least about 20 feet by 20 feet for one table is what is recommended and what we use. And it's possible to do it. These are AHUs. Today AHUs are miniaturized. They're not very small, but much smaller than the conventional ones. They can be hung under the roof. If you have that, I'll just take 1 minute. I close. And these are the 3 operation theaters where we have AHUs. And it's a big science, and you'll have to take professional help in them. Everything that you have in the environment has to be controlled. Humidity and temperature has to be controlled. Humidity control is essential round the clock. Temperature, you can switch it off at the end of ACs, you can switch it off at the end of it. But see that you have standalone dehumidifiers like this, and see that the humidity is controlled between 40 and 50 throughout the night. So we have a reporting system wherein as soon as they enter, they have to tell me what is the humidity in the morning when somebody entered operation theater. It should be around 40 to 50. If it is 60 and above, then there is a chance that microbial growth is happening throughout the night when you are not there. All the medicines should be kept and accessible, and audits are very important in any operation theater. This contains all this small tray-like box. All the medicines are written there in alphabetical order. A is there and the Z is there. So it's very easy to pick up in case there is an emergency. Do not dirty the things thinking that it's going for cleanliness anyway. Bioburden has to be reduced. Monitoring of sterilization of instruments is a very big science, but that's a part of the SOPs that we have. Everything has to be written down like this. And post-operative OT processes, audits and analysis are a very big thing. What I would recommend is NABH, ECO, internal audit points are there. and this is very good. It's available free of cost. You can buy the book also from NABH. You may or may not enroll into NABH. We have taken the NABH assistance in a big way, and last 12 years we have been NABH accredited. We have gained a lot by that process. A lot of discussions are digitally circulating that NABH is that excess. It's not necessary, but ask me, NABH is absolutely essential to control or have a vigilance on what your hospital is doing. There's a lot of learning points that will bring safety to the practice that we are doing it. And it's available, and you follow the guidelines. Then you can apply and get the NABH clearance. Monitoring and reporting of infections, as been told, it's very important. We need to report at various levels. Internal audit is very important. This is where NABH audit points will come into role. We all should be able to trace a sterile pack at some point of time. See, you have autoclaved or UV2 sterilized, and your packs you have distributed to many places. And in case there is a problem, you'll have to trace all of them back. That's only possible when you have a recall mock drill is periodically performed. So again, you'll have to learn it through practice. And vendor evaluation. You may be buying so many things, but then you'll have to actually visit the store of vendor, see how he is maintaining it, how is the company. Wherever I go, I will go to the company and see how it's being manufactured. So vendor evaluation is absolutely important. Don't take his sales words into consideration. Your water, your air, the way you store in the hospital, the way you receive the goods. This is a very important thing. The moment anything comes to the hospital, see how it is packed, how it is kept, see how it is. See, this is a pack of drapes which has come to us, and obviously the inside drapes will be good, but then we'll miss out on contamination if we do it. So, friends, as the practitioners of ophthalmology, we have great responsibility towards the society, towards the patients, towards the individual eyes, and we need to be very vigilant of what we are doing so that we do justice to the work we are responsible for. Thank you so much.
I thank you, sir. Thank you so much for your presentation, and we'll have the discussions at the end. Now, Dr. Samina was supposed to be presenting on importance of documentation. Instead of her, Dr. Uday Gajiwala will be presenting, and over to you, sir, for the talk.
Yeah, one more time, good afternoon, and let us understand what all needs to be documented. So, I just want to bring this to your notice. There is a very good book written by Dr. Atul Gawande. The title is The Checklist Manifesto. He has moved around a lot of industry and found that everybody follows some kind of a checklist to make sure things don't go wrong. So this needs to be done in our activity also, and there is a surgical safety checklist given by WHO, and if any of you is not practicing timeout procedure, I would strongly urge all of you to practice timeout procedure. Sign in and sign out are also important activities. Pre-operative checklist needs to be filled up just before the patient is entering the theater. That has to be signed by the theater nurse, the OT nurse who gives block, and needs to ensure that everything has been done as per the protocol or as per the suggestions of the doctor. There's a logbook of autoclave cycles that need to be maintained. It's called mechanical monitoring of autoclaving, and what time the heater was turned on, what time we reached the required temperature and pressure, and what was the holding time. All that needs to be recorded, because as Dr. Chandrasekhar said, class 1 indicator only indicates that the temperature was achieved. So here at least the logbook will tell us that the cycle was run properly. This is the autoclave strips registers that we maintain. 3 things here. The strip color must be jet black, because it indicates only the color the temperature has been reached. So if the color is not jet black, believe that the temperature was not achieved. This needs to be signed by the theatre in charge and by the surgeon both, and both of them are certifying that the color of the indicator strip was jet black. Similar register can be maintained for fast autoclave, the flash one, for ethylene oxide gas sterilizers also. Then we are using biological indicators which need to be used every week. That needs to be sent to the laboratory, and at the end of 72 hours, if no growth is seen, then we can certify that the sterilization had actually occurred. So this also needs to be reported, and a register need to be maintained. Cultures taken from sterile and unsterile items, report of this culture is also, I mean, this is about air sampling. The air sampling can be done using open dish sedimentation technique or by using air sampler, and culture sourced from sterile and unsterile items report need to be maintained. Not just that, how to interpret the report is also very important. So the growth of gram negative organisms or fungus cannot be tolerated at all. Gram positive organisms, a few colonies from unsterile area is okay. So sometimes I have seen people reject everything if there is a culture report comes positive with a few colonies from unsterile areas. We have not sterilized the unsterile areas, say for example the OT table or the wall or floor. There can be some growth. So how to interpret the report is also very important here. We need to maintain record of whatever material consumable that we use. As Dr. Chandrasekhar sir mentioned, the consumables were reused without re-sterilization, ended up with cluster infection. So the batch number and the expiry date need to be mentioned in the register. Similarly, there are several tasks being performed inside the theatre. Somebody does the job of fumigation, somebody does cleaning, somebody does cleaning of the overhead tanks. All that need to be recorded, and only then we'll be able to fall back upon these details to cross check in case of a problem. Then there are several checklists that we fill up. There is one daily cleaning checklist, there is a weekly cleaning checklist, there is something monthly, and also a quarterly. All these reports, and Dr. Gawande also very clearly said that keep the details on the each checklist minimum, and most likely the answer should be yes or no, so that the people who are filling up don't have to spend so much time and they really do it well. So all these need to be maintained. Only then we can retrospectively find the root cause. Unless we have the line listing of who was the surgeon, who was the assistant, who was circulating staff, which operation theatre was used, under which microscope this surgery was done, etc., and the chronology of the surgical order. Only then we can find out if the second and third cases were infected, or all the infected cases were operated by the same surgeon, etc. If we have not documented these details, there is no way we can find out anything. Similarly, if you have maintained details of the batch number and expiry date of the irrigating fluid and other consumables, we can really understand if anything has gone wrong as far as these consumables are concerned. Autoclave strips register will tell us whether the job of sterilization inside the hospital was done properly or not. All the activities register will tell us whether this particular activity was done or not, who did it, when that person did it. So unless these are there, we cannot investigate root cause, and whenever we try to investigate where we did not find this information, we could not go into further details. But as Dr. Chandrasekhar also mentioned, if these details are maintained, we can exactly pinpoint the root cause, and at the end of everything, if there are legal issues coming up, then this documentation will be the only savior. So at the end of the talk, I would like to say that documentation cannot be overemphasized. It is mandatory requirement, and we all must do it. Thank you so much.
Thank you, Dr. Gaziwala, for wonderfully elaborating upon the importance of documentation as it happens, be it in a clinical level or in even in OT practices. So now the next talk is by Dr. Ramesh Dorairajan. He would be speaking on what does a team look for and how to report a cluster in event if you are amongst that, if you have that unfortunate situation.
Thank you. Can I start? So in India, we have two national level programs where we are supposed to inform them about any adverse event in our hospital. That's the Pharmacovigilance Program of India and the Meteorovigilance Program of India. And please do also inform us at the AIOS Adverse Events portal. So these two come under the Indian Pharmacopoeia Commission, which was originally attached to the AIMS Delhi, and about 4 years ago they moved to their own place in Ghaziabad. So who can report? Any consumer or patient or physician or pharmacist or nurse, anybody who's involved can report. Interestingly, much of the reports are coming from the pharmaceutical industry themselves. About 60% of the adverse events reported to the Government of India are coming from the trade. What to report? You can report any non-serious or serious known or unknown complication. It can be minor or it can be death or life-threatening. So how do you report to the government portal? You have a web page, you have a toll-free number, you have a Twitter handle, you have a mobile app. So it's easy to report. You just Google adverse events Government of India and these various options will come up for you. So about 60,000 adverse events have been reported in 2021 in India. India ranks 9th in the WHO list of adverse events gathered. And we have about 350 monitoring centers, and these are usually the government medical colleges. Now, when you report, the patient details are kept in full confidence, but the reporter's details are all captured. The reports are very simple, and you don't have to fill up every column. Whatever you know, whatever you feel like, it can be reported. The government captures the data. They don't come back to you ever. They monitor the number of reports, and if you have a number of reports about any particular drug, then they decide to take action and they contact the company involved and they interface with them. You have a separate reporting form for medical devices. You have a shock from your OT table. You have something wrong with your phacoemulsifier. Something is not working with the equipment that you use. You have to use this particular form. So those two are as far as the government rules are concerned. How many of you know that we are having an adverse events committee and a reporting site in our own website? Thank you. So you have a green adverse registry link. If you go to AIOS website, you have a small link. When you click on that, it goes to 3 pages. So what we look for is what is actually captured in these 3 pages. We had a recent report of a person who had a mature cataract. He was operated by a doctor in central India. Within a week, he had a mature IOL. 8 days later, he had to reoperate and remove the intraocular lens. Another doctor was lucky. He opened the pack and he found a white intraocular lens, so he didn't implant that. But all these events were not properly reported, and so we could not follow up on this. So please do report if you have 2 or more cases of any adverse event, including TARS and endophthalmitis. Although for large volume centers, it is like 1 or 2 or more events in one theatre or 1 week. The British guideline actually says if you have a run of more than one infection every 350 surgeries, you please consider it to be a cluster. So for a low volume surgeon, you may be having an endophthalmitis once in several weeks or months. But if your endophthalmitis rate is more than 1 in 350 surgeries, please consider it to be a cluster and take action. Infected medical supplies are an unfortunate reality in our country. We see WhatsApp messages. We need to gather this data so that the AIOS can then talk back to the infected supplies. Unfortunately, get blamed on the surgeon, and the surgeon is often he's not the person who actually is responsible for this. So unless we have a large amount of data, we cannot represent the members properly. So what we look for? We look for the source of infection. We look at the OT zoning and sterilization processes. These were covered earlier. We also look at the protocols and the OT practices. So in the first page, we capture details such as the name of the person, the center, what actually happened, a short case summary of the patient. In page 2, we capture information about the instruments and the reprocessing which was done. do you have included in IA tips? Are any of you reusing the equipment? And how exactly do you clean them? Do you use tap water? Do you use deionized water? Are you using enzymatic cleaners? All the common causes for TARS and for breaks in sterility are captured in page 2. In page 2, the questionnaires are related to the product and the consumables that you use. What drug you use, what intraocular lens you have used, what reduced intraocular pilocarpine, and chemicals and the products used. The team will also look at the registers and the documentation that you have done. This is very important because after you take care of the patient, you may be legally liable, and the legal liability will be strong from your point of view only if you are maintaining proper record of what you have done. So your registers and documentation will have to be done. In a number of cases, Dr. Chandrasekhar and other members have spoken to various centers and helped them to make sure the documentation is in proper order, because in the months and years ahead, these will be argued out in court. So findings in one of the hospitals that we went to was that Cheadle's faucets was still being used. Eye drop bottles were found in the OT area without a cap. OT sterile bins did not have a sterilization sticker. The date of sterilization was not present on the OT bin. Unfortunately, in this run of end off, the patient did not have a discharge summary in their hand. Post-op notes were not entered. This was failure of systems at various levels for which the unfortunate doctor gets blamed. And particularly Dr. Moria, Dr. Uday, Dr. Bhavanakula should be thanked, because they went to this particular center where a government doctor was involved. They saw the patients pre-op, post-op. They saw the post-op and they agreed with the treatment. They guided them. They spoke to the dean. They spoke to the health minister, and they got that particular doctor reinstated. So the committee are taking extraordinary efforts. When you ask them for help, they will come and help you. In one more hospital, one single infected vial of intraocular drug was used in 4 patients, all of whom had multifocal lens implantation done. The other patients in that list who had a monofocal did not have this particular intraocular drug use. They all escaped. So when you share a single drug across multiple eyes, you risk converting one end-off into a run-off end-off or a cluster. So don't do it. Especially in well-off centers, those of you who are well-off, please use one drug per patient. If you are a large volume center with proper protocols, you can share a single drug across many patients, and there are very, very good examples of people who are doing that well. But then it doesn't apply to 99.9% of the doctors in India. We cannot do that. So all of you who are on low volume centers, don't share your drugs across more than one patient. So we don't want to face a problem like this. Please do contact the zonal members. Please do contact Dr. Santosh Hanover. Please do go to the AIOS website. We'll be happy to help you. Thank you.
Thank you, sir. That was, I think, an excellent information. I just had one question. What happens after the report? What is the next sequence?
So we are not able to follow up on each report, and the reports are generally we have to see whether if you have multiple reports, then usually some action is taken. For example, one particular doctor which is currently being investigated had a series of about 15 patients over a period of 2 months where she had problems. So we are taken samples from that particular hospital, and we are having the various tests done. Till now, most of the tests have come out as normal. So once we find out a problem and we are able to analyze, like we found with the Sunways product, with the intraocular pilocarpine, we will send an advisory. So if you find multiple centers having the same problem, or several samples of the problem occurring in the same hospital, we will take action. As of now, we are not taking any. We are just observing when we have reports from any one center with one or two infections or TARS.
Thank you, sir. That's very useful.
Advisory will be sent.
Yeah, it's very useful to hear that, because, as you said, we need to have information from multiple sources. We cannot do any change with just one source. Yes. So this is very good that we can collate this information and then approach.
So this will work only if everybody is willing to report. Yes.
The challenge for us is basically for AIOS is people shy away from reporting this. Yeah. Any adverse event, because they feel they are guilty. The most important thing, all the members have to note that they are not necessarily guilty. It's an accident which has to be reported, and probably like in the Chhattisgarh case where we helped out them in, means you know that doctor was in so much of a depression and she had to be almost suspended. She was suspended rather. We can give them not only a moral but a social. We were the people who spoke to the media, because a person in a periphery will not necessarily know how to interact. So these are the things what an AIOS can offer on behalf once we come across.
Oh, just 2 minutes, sir.
Good care, whatever complaints are there. So, under leadership of Dr. Santosh Unawar and Dr. Uday Gajiwala sir, we are doing it.
Correct. So 2 minutes, Arvind sir.
Sir, please.
Madam, two aspects to it. One is the pharmacovigilance program of India, which will not get back to us. But like with intra-Avastin, if they collect data of the same thing, then they take action and they can give an advisory. Whereas in AOS, we have three kinds of situation. Some people want to report, but they don't want us to investigate and help them. Some people are fully for helping them, then we are there to help them. Not only that, but within inverted commas, we give them the best possible thing. And the third group, they don't want their name. Definitely, none of the hospitals or the surgeons' names are disclosed. So this also is driven by the consumer. If they report, actually in one particular instance, it helped a lot of people. It is not only helpful for them, for others also from using those things. And AOs also, we deal with the companies with all legal advices. Thank you, ma'am.
Thank you, sir. So we'll go on to the next talk by Dr. Arvind Kumar Moria on perioperative measures.
So good afternoon, everyone. My talk is on a standard pre-operative protocol for the intraocular surgeries. So what we understand by this word sterilization? So it is, does it mean killing all the microorganisms? Is it the right definition? So this is the operational definition. So it is a carefully designed and monitored process that will assure the probability that an item being contaminated to be equal to or less than 1 in million, and the sterility assurance level, the predictor of the efficacy of the whole sterilization process. So these are the operational definitions. So sterilization process is a probability function and not absolute. We must need to understand this. And there is a chance of 1 in million spores surviving this whole process. So regarding the OT sterilization or disinfection, the eye surgeries, they need to be done in the dedicated IOT. And this is the suggested layout in short. So there needs to be outer zone or the protective zone. At the reception, the mid zone, clean zone or the common area, that is the changing room or the transfer zone. Then the aseptic zone or the sterile zone for the scrubbing, gowning and gloving, operation room and autoclave room. And then of course the disposal zone, that is equipment and supplies are processed. Fumigation. So starting OT for the first time after long time or after civil work, at least 3 OT washings followed by fumigations, and we need to get 3 consecutive negative cultures in OT is mandatory. And fumigation is not required if there is positive pressure ventilation in the OT. In the running OT, single fumigation or disinfectant mopping or fogging weekly is enough, and use of fogger machine is preferable, not mandatory. And formalin can be used for fumigation. But now there are newer protocols, so it is no more needed. Bacillocid special or Desnet. So the active ingredients are glutarol 100 milligram per gram, and then a bacillocid fumigation and bacillocil, and the ultraviolet radiation. These are preferable, ultraviolet radiation not mandatory. What are the important considerations? So study shows no consensus of benefit of HEPA filters. Central AC not necessary. Split AC is okay. No window AC. It's a big no. Need for AHU is questionable. Regarding the air conditioner maintenance, we need to clean filters every week, servicing and cleaning every month, and we need to document it. Floor, microscope surface, sinks and drains, horizontal surface, they must be cleaned daily. And walls, if tile, should be washed up to minimum 4 feet height, and floor may be washed or wet mopped at the end of OT, and 2% bacillocid special is needed, and no dry dusting or vacuum cleaning is to be done. Size. So 160 square feet per 4 persons, that is 400 square feet as desired by NaBH is not practical, so we can reduce it proportionate to the number of people entering into the OT. Now coming to the sterilization of the instrument, so adequate reserve sets needs to be available, preferably ETO, autoclave or flash autoclave. In between cases, autoclaving to be done and documented. And class B autoclave for recommended for long tubings and for re-sterilization. Chemical sterilization or formalin boxes and Sidex not at all recommended. Water quality, so it needs to be distilled, deionized. RO water also will do, but no tap water. So these are the physical characteristics for the water we are using, because in a recently outbreak it was because of the water supply this cluster endophthalmitis did occur. Monitoring of sterilization is very important. Chemical indicators, there are 3 indicators. And then the biological indicator testing needs to be done once every 1 to 3 months. Logbook needs to be maintained, and maximum use of disposable instruments, and there needs to be surprise checks. Periodic cultures are needed, and autoclaved or ETO instruments and standard quality irrigating fluids or dye and viscoelastics. Training is very important, so periodic assessment and training of the OT personnel through seminars and educational videos. And of course, there is a lot of power in documentation that is very important, and along with the microbiological surveillance. And these are the algorithm regarding the blood sugar level. So 140 milligram and maximum 200 milligram, and BP 160/95. And preoperative Roplas and syringing needs to be done, but no syringing on Roplas on the day of surgery. If there are infection, so postpone the surgery and manage infection, and then only we need to operate. No contact procedure like the biometry or tonometry on the day of surgery. So we need to go for DCR, and after 4 to 6 weeks, cataract surgery needs to be done as per this study. Systemic condition, immunosuppression, uncontrolled diabetes, unexplained fever, renal pathology, so they need to be treated before surgery. Seropositive patient, these minimum standards, these are the universal precaution. And also we can do at the last, as a last case, and the patient needs to be well hygiene before taking into the OT. And so we need to follow the best practices. And thank you so very much.
Well, thank you, Dr. Muria sir, for being very crisp about the details, and he talked about the AIOS guidelines. So that is from the AIOS. Next, we invite our well-known Dr. Nirmal Frederick, the legal expert of the country and member of many different fora where these guidelines are formulated. So over to Dr. Nirmal sir.
Thank you, Uday sir. Since the time is short, I'll try to speed up the things. As it happens, we come to the medico-legal expert as the last option. So same way the talk also is the last talk here. So this is the real statistics that's bothering us. 90% of all the cases in medical negligence involved hospitals, and 12% decided by consumer court or on medical negligence. And the capping is there for all our payments and other things, but unfortunately court doesn't consider capping for medical negligence cases, so it is average 25 lakhs to 70 lakhs now, and earlier 10 lakh was considered as high. So the real fact is 400% increase in cases of medical negligence every year, and the compensation, so this is a landmark case where documentation costed 11 crores for the hospital. So this is the status of ophthalmic practice now. If you Google, there are 250 odd documents about litigation for during ophthalmic practice. So it's all started with this case where a MD get jailed for surgeries that cost 67 of their vision. So this is the present status. Every poor outcome is considered by the lay public and patient as negligent, and every infection is botched surgery for the media, and the nation wants to know everything. So one interesting law in our country is law grants compensation according to the patient's financial condition and earning capacity. So whenever you are treating a HNI or wealthy patients, always consider your cost compensation. So the risk and liability compensation is more. Unfortunately, our fee is same for all patients. And the next regrettable truth is medicine is one professional course where law is not part of the curriculum. All other professional course there is a at least one semester on legal aspect. And another fact is if there is one event, something wrong or suspected negligence, a doctor can be sued simultaneously in 6 or 7 forums. This is a long list of forums, starting from medical council, the state council, criminal court, civil, consumer, human rights, and of course now the Clinical Establishment Act, where the hospital can be sealed. It has happened, so we are all fighting this battle. And what are the challenges unique to Opthal? One is outreach services where clusters can happen, and daycare surgery, so the follow-up issues are always there. There's no one to take care of the emergency issues. Complexity of payment, paid services, free services, now charity units, and charity done for the insurance companies. So we are all doing that. And queries, documentation, and advertisement, over promise and under delivered. Recently one lawyer came with the advertisement of the hospital promising 100% guarantee, and the patient is not happy with the vision, so that's why he has come to the court. So before going to that, we need to understand certain basic terminologies. Negligence, doing something that one is not supposed to do, or failing to do something that is supposed to do. Commission and omission is considered as professional negligence. And vicarious liability, so like doctors, if you are running a hospital, if the employees make any mistake, the owners or the leaders are responsible. So there's a principle of respondent superior, and this is one thing that has helped us mediate many cases, contributory negligence by the patient and the team. So if you can write something in the note that patient does not apply drops or not taken care or come for follow-up, that is the most important defense in case of negligence. And this is another principle, res ipsa liquita, the things or facts speaks for itself. This is what happened in many of the negligent cases. And misadventure, if you are trying a new IOL, new implant, new procedure, new drug, that is not mentioned in the standard textbook or curriculum, then it is seen as a misadventure by the court. And condition to be satisfied proving liability are these 4 D's: duty, dereliction of duty, direct causation, and damage. So what really happened to the patient. So the second aspect, I will not go into the details, all the previous speakers has covered it better. And so only people who do not get endophthalmitis are those who do not operate. I'm sure if you are operating, you can get endophthalmitis. And these are the data. Intravitreal injections and endoph is a common cause of allegation in the medical negligence cases. High number of cases and very high award. And coming behind is the toxic TAS. And see, these are the CPA cases. Single case negligence has to be proved by the patient and the team. And in cluster infections, you have to find ways to defend yourself. And these are some of the landmark cases where doctor is not liable, but hospital is liable for sterilization failure because it's a vicarious liability on the part of the staff. And this is one case, Teg Bahadur Hospital, post-op end-off is a known rare complication. So no negligence proved by patients and the case was discussed. So not every case goes this way. So present scenario is clusters do happen everywhere, not only for camp setting, but many are not reported, not notified. So how what to do? And very often most of our doctors get jittery. So how to save yourself? So these are the answers we need to find out. I will not go into the details, but main thing is liability arises from 2 reasons. One, delay in diagnosis. So we need to do essential diagnostic tests if we suspect endophthalmitis. And so we need to have a high index of suspicion, especially in these cases, penetrating injuries, comorbid conditions, and if there is a PCR or a delayed surgery or multiple surgeries. So to avoid delay in presentation, we need to tell the patient in in the discharge itself, language, in the same language he speaks, pictorial signage, and state the symptoms that warrant contact tube, like blurred vision, red eye, severe pain, or photophobia. So a structured discharge summary can really help. And also we need to train our staff to understand what are the risk factors and what are the signs that they should escalate to us, and have a system in place for emergency and midnight calls. Most of our hospitals are daycare centers, so we need to have a system in place. And investigate all cases thoroughly, report. I will not go into the details, and this is very, very important. Refer to or call your retina specialist immediately. And so the fourth aspect is there are 4 preventive steps, 4 levels. Primary prevention is protect against a complaint being filed, because once we find there is a issue, we need to break the bad news to the patient, and from then the senior person or the leader or the surgeon has to take charge himself. Don't delegate it to the junior most staff. And second level is protecting the doctor from being held negligent. Tertiary level is direct financial consequences, indemnity and insurance policies. And community level, we need to develop certain rapport and work with the professional associations. So these are the potential areas of vigilance and safeguarding, which Dr. Moria has already highlighted. I will not go into the details, but the consent is very, very important. Please try to get the consent in the language the patient understands and speak. And these are resources which are readily available in AIOS and many of the state societies. This is the most important aspect if you are going to deal with a medical legal case, breaking the news. So use simple lay language, stay with the patient, make sure patient have emergency access to the medical team, and also we need to handle the breaking bad news properly with good communication. And of course, good documentation really helps. Poor documentation helps the patient's lawyer. So these are some of the court judgments related to endophthalmitis. If you are doing any investigation, please safeguard themselves. The findings must also be recorded in the case record, and record the previous treatment treatment taken elsewhere also. And also, if you are taking second opinion, ensure second opinion in complicated cases is duly recorded. And if patient doesn't comply with your advice and goes to another place, please write that in the document also. So never take over and above your capacity, avoid over promising, and if it's not your specialty, if you are only a cataract surgeon, please refer to a friendly retina surgeon. And report all infections. This is very important. I think Ramesh has already highlighted about the adverse registry. So now this is the most important aspect. This is the frequent calls we get. Invariably the calls come after 9 p.m. So how to defend if you receive a notice? So don't be frightened, stay calm, avoid anger, take some rest after you see the notice, review and understand the complaint. What exactly is the complaint from the patient and the lawyer? Carefully read the complaint at least 3 or 4 times, don't rush up, assess the clinical details, get access to the patient record as well as patient details. So gather all the documentation, complete patient records, consent forms, pre-operative, post-operative instruction you are given, and also the follow-up records. This is very, very important. Please resist the urge to tamper the case sheets. So this will be the first evidence for the lawyer in tampering of case sheets. And also get the patient communication record. So prepare a written response yourself on the first time. Then you can seek the expertise of a lawyer and respond within the specified time frame. The first time reply can be very simple, that we acknowledge your receipt of notice or the lawyer's notice. We will respond within 30 days. You need to have a structured format, organize your responses with clear sections, never rely only on the lawyer's response. So you have to ensure you see the response and correct each and every word of that response. And maintain a respectful and factual tone. Avoid any language that could imply guilt or defensiveness. Never feel or never say sorry in your reply. And adherence to standard protocols, you need to emphasize that. Highlight that standard of care was followed in that patient. Mention the complication risk as mentioned in the standard textbooks. And also you can get an independent expert opinion and attach the expert opinion supporting your case. Ensure you follow the national guidelines and also refer to those guidelines. The most important thing is take indemnity cover. So there are a lot of options now available. AIOS cover you is there, and if you are in a other professional association, there are many legal schemes now. Take the help of professional peers in association. Have a good rapport with local colleagues. Most of the cases is started in another doctor's clinics, so ensure that you don't badmouth your colleagues. So reach out to IMA or AIOS crisis committee, and also maintain a good rapport, brand and public relations. So all these are efforts during the preparation of this second editions. So this is coming up. So ensure you even if you don't go for accreditation, please ensure you follow the standards listed in this guidelines. So the best way to deal with medical legal problem is to prevent it, and healthcare is an art as well as science. So we are good at the science aspect, but need fine tuning in the art component. Hope we don't end up in this battle. The best battle is the battle that is never fought. The best war is the war that is won without a battle. Thank you all, and thank you for the opportunity.
Due to lack of time, we'll wrap up the session here. Dr. Muria sir has some announcements.
We will take just 5 more minutes. A few announcements are there. So in our pursuit for all the ophthalmologists in our country, so there is this presidential committee, that is AIOS Adverse Event Committee, and we organized the first competitive this disinfection and sterilization course with 10 modules, and it is still in the archives. You can go there, log in and watch all the 10 modules. So now I would like to call upon the chief editor, Professor Purvi Bhagat, and this is ready reckoner sort of thing that we have prepared of all the 10 modules. And I request all the esteemed chairpersons to help her in inaugurating this ready reckoner.
Can we invite the other members?
Yes, I request all the other members of the AIOS Adverse Event Committee to come up on the dais.
Please, please.
Dr. Tejas, kindly. Mukesh le lega. Yes, kindly come in front. Be in the center, chief editor.
Big book. I'm going to stand.
It will be sent to all the AIOS members in this form. So I hope it will be very helpful. And there are, it's a presidential committee, so there are few changes in the core committee. So Dr. Uday Gajiwala sir, he will be taking as a national advisor from the post of chairman. And Dr. D. Chandrasekhar sir, he will be the new chairperson. And co-chairperson will be Dr. Ramesh Durai Rajan. And Dr. Puri Bhagat will be the member secretary, and myself as the national convener. And we have this Chetna Ben Desai also. She will be there as a pharmacovigilance expert in this committee. So these are the few newer changes, because change is the only constant in the AIOS Adverse Event Committee. And the joint member secretary, Professor Barwa, is here. Kindly come on the dais. Yeah. Okay. Thank you.